This is my incredible honor to introduce Dr. Christopher Wilcox. Dr. Wilcox did his medical training at Oxford and London University before coming over to the States, where he was a faculty member at the Brigham and Women's Hospital and at the University of Florida, where he was the chief of the VA, before joining us at Georgetown as the division chief here in nephrology. I tried to actually print Chris's CV. My toner actually run out because he has more than 200 publications. He really is a pioneer in physiology, and more importantly, he does things to try to really treat those that have abnormalities in these physiologic processes. He's been actually given the Lifetime Achievement Award by the American Heart Association. And one of the things he helped discover was something called tubular glomerular feedback, and really some of the SGLT2 inhibitors and how they work to help with heart failure and chronic kidney disease is based on what Chris discovered years ago. So again, it's my honor. Chris, thank you for speaking to us today.
So thank you, Mike, for that very generous introduction. And thank you for the opportunity to discuss what has been a long-standing interest of mine, which is diuretics, how they work, and the basis of diuretic resistance. And I'll be approaching it from the point of view of pathophysiology as applied to treatment. So you'll see as we go along that my first interest and first job actually was zoology. And you'll see that I've chosen to illustrate the talk with some pictures of these beautiful birds. They're not my pictures, I have to say that. Mostly not my pictures, but come from the internet. Never mind. So I'm going to talk about the definition of diuretic resistance, what is meant by the breaking phenomenon, which is really the basis for the problem, and some of the mechanisms behind that in diuretic resistance, and then apply it to heart failure and discuss with you 4 new approaches to diuretic resistance in heart failure, some of which I think will be new to you, and also the nephrotic syndrome, and always with an eye to what the future may bring. Some of what I said, most of what I say is already applicable, but there are a few things I'll tell you as we go that are presently experimental. I want to say at the beginning that I'm the chief scientific advisor for a small company called Sarfez that's making an extended release form of torsemide. And I bring it up because I'll show you a couple of slides from peer-reviewed publications that we've done on torsemide, but you have to bear in mind then that I am somewhat conflicted in that regard. So diuretic resistance is actually tricky to define in a quantitative way. We could just spend most of the talk on that, but usually we recognize it as continued congestion or edema despite a full dose of a loop diuretic, since loop diuretics are the most potent diuretics that we have. And there is a ceiling dose for furosemide, which is established to be about 80 milligrams once or twice daily. Increasing doses above this do not produce worthwhile further reductions in edema or congestion. So this shows you diagrammatically the beginning of diuretic therapy in somebody who's sensitive or responsive in green and resistance in red. So that on the first day, the normal subject gets a large increase in sodium excretion above the level of intake, leading to a loss in body weight. And each day for a first day or two, there's a further increase above body weight and loss of body weight, above intake and loss of body weight. But eventually a new equilibrium is attained when salt intake equals salt excretion, and body weight loss ceases. This is the so-called breaking phenomenon. In a subject who is diuretic resistant, there's a diminished loss of sodium, which is diminished and foreshortened, leading to only a modest fall in body weight. So that in the steady state, you can see that there is a difference in loss of body weight during diuretic therapy, but both subgroups achieve a sodium balance after a number of days, such that salt excretion is similar to salt intake. So diuretic resistance in a steady state and diuretic responsive and resistant subjects have the same sodium excretion, which is equivalent to salt intake. And so measuring sodium excretion is useful to assess salt intake, but it's not adequate, not helpful to assess diuretic resistance. A number of years ago, colleagues and I looked at the impact of salt intake on the normal response to 3 doses of loop diuretics given under metabolic balance conditions. On one occasion, we took a very high level of salt intake of about 280 millimoles a day, or about 75 millimoles per 6 hours. And this plots sodium excretion in millimoles per 6 hours of the day. We had this salt intake for 4 days prior and came into balance. And you can see that salt intake equals salt excretion here. We were in balance. The first dose of furosemide, 40 milligrams IV, produced a large loss of salt, negative salt balance shown in gold. But the remarkable thing was that this was followed by 18 hours where the kidney retained salt avidly. So at the end of 24 hours, salt loss was matched by salt retention, and there was no net loss of salt or change in body weight. And next day we had it orally, the last day intravenous, it was the same increase in salt loss followed by renal salt retention. So at the end of 3 days, this group, there were 10 of us, had no net change in salt balance, despite a very effective acute natriuretic response because of post-diuretic salt retention. We were randomized to also another period where we took a very low salt diet of 20 millimoles a day throughout. We were in balance, as you'll see by the very low salt excretion. Furosemide led to a loss of salt, albeit not as much as on the high salt diet. But there was no way now the kidney could restore salt balance because there was virtually no salt in the diet. So although sodium excretion rapidly returned to near zero levels after the diuretic, that did not restore salt balance. And at the end of 3 days, we'd lost approximately 1 kilo of body weight and 150 millimoles of sodium. So on a high salt diet, the diuretic had merely set in process an ebb and flow phenomenon, salt loss followed by salt retention. But salt restriction then was required to induce a negative salt balance, even with a very powerful diuretic, even in us who had no underlying salt retaining conditions. And in practice, a daily sodium intake of about 80 to 120 millimoles, 2 to 3 grams of sodium daily, is a good goal for a patient with at least modest salt restriction. A more severe salt restriction is occasionally needed with very severe diuretic resistance, but it's often engenders a fall in renal function and other complications. So clearly it would be interesting to know what is the cause of post-diuretic salt retention. And our first thought, reasonably, I think, was that it was a response to the volume loss. Here's a large loss of salt and volume. And indeed, when we measured increases, when we measured renin, angiotensin, aldosterone, or norepinephrine, before and after the first or last doses, we saw large increases even on the high salt diet. So activation of these systems might well have caused the salt retention. We undertook further studies in which we blocked these systems by giving captopril and prazosin round the clock, which was effective in preventing any changes in angiotensin or sympathetic nerve activity. But we got just the same pattern of salt loss followed by salt retention. So clearly that was not an adequate explanation. So in this study, we examined directly whether salt loss, volume loss, was required for the period of salt retention after a loop diuretic. And here we took a 100 millimole per day salt diet for 3 days before and throughout the study. On 2 occasions, we had, when in balance, an infusion of 100 millimoles of sodium, about a third of a liter of saline, intravenously. And the kidney remarkably excreted 95% of that extra sodium within 2 days. On a second occasion, randomized and crossed over, we had a single dose of bumetanide, 1 milligram IV, but this was accompanied by a variable replacement of a variable infusion of saline to match the sodium, chloride, and fluid loss so that we never became volume depleted. And when the diuretic was finished, we had the load of sodium again. And on this occasion, when we'd been exposed to the diuretic but had no volume loss, the kidney was no longer able to excrete the salt loss. So this told us then that post-diuretic salt retention is not a response to volume loss. We could get rid of this idea quite clearly, but a memory effect of the tubules about some pharmacological response of the diuretic on the kidney. So what could that be? And here I had to resort to an animal model. It's the only animal data I'm going to show you today. But this is an electron micrograph of the distal tubule of a normal rat. And below is the distal tubule of a rat. And this rat had high salt intake, by the way. And here's the distal tubule of another rat, which was given furosemide for 5 days and a high salt diet. And you'll see the massive hypertrophy of the distal tubule. These are the basolateral enfoldings where the sodium pump, NAK-ATPase, is expressed. And indeed, we found not only this structural upregulation, but 3 times as much sodium potassium ATPase activity. And also when we perfused the distal tubule with micropuncture, a greatly increased capacity to reabsorb sodium in the distal tubules of rats that had been exposed to furosemide. So this led to the concept then that furosemide acts on the thick ascending limb of the loop of Henle here, which is a major site for sodium reabsorption, so it's a powerful loop diuretic. But after the kidney has been exposed to furosemide, there are adaptations downstream in the early distal tubule, which is the thiazide-sensitive segment, and also in the collecting ducts, the amiloride-sensitive segment, that entail both hypertrophy and increased functional capacity. So that the kidney is then transformed into a salt-retaining kidney, and that these distal segments, which normally do not reabsorb very much sodium, this reabsorbs about 3% of the filtered load compared to 25% of the loop in the loop, but these now become major sites for sodium reabsorption, and therefore should be major sites for thiazide, such as chlorothiazide shown here. If this is correct, then chlorothiazide should become a very effective diuretic in patients who are resistant to the effects of furosemide. I'll just show you one clinical example here of a patient who is very resistant to a loop diuretic. And you'll see here that this patient who had nephrotic syndrome due to membranous glomerulonephritis had 240 milligrams a day of furosemide and despite that was grossly edematous with compromised respiration. The high dose of furosemide had induced severe hypokalemia despite 40 millimoles of KCl daily. Giving the dose twice a day and upping the dose of KCl to a rather high dose of 80 led to a small loss of body weight, but really frankly quite small, and serum potassium rose only to the bottom of the normal range. Now you'd think that 25 milligrams of hydrochlorothiazide would be a small gun to fire in somebody who was already receiving 120 twice a day of furosemide. But you'll see that actually the thiazide led to a progressive loss of fluid, about 10 kilos of body weight, but with it, a loss of potassium and a return of hypokalemia despite the potassium chloride supplements. So at this point, we gave an aldosterone antagonist, eplerenone or Inspra, and that restored at least a low normal serum potassium and may have led to a small further loss of body weight. So this shows the value then of considering additional diuretics in a patient who is showing marked resistance even to the most potent diuretic, the loop diuretics, and how it may be valuable for management of diuretic resistance. So we can extend this concept to a number of diuretics here, and I'll come back to some of these as we go through. For example, we know that in some states of diuretic resistance is enhanced reabsorption of salt in the proximal tubule. And so diuretics that block this and pass on more salt to the furosemide sensitive segment might help to relieve diuretic resistance. And here carbonic anhydrase inhibitors act in the proximal tubule but are not clinically terribly useful. What I will tell you about is some studies we've undertaken with sodium glucose-linked transport 2 inhibitors, such as dapagliflozin, empagliflozin, and canagliflozin, and how they interact favorably with loop diuretics. Furosemide is actually an impaired loop diuretic in that it has a very variable bioavailability of 10 to 80%. And switching to torsemide, which has a much more predictable bioavailability of greater than 80%, can improve diuresis sometimes. And all diuretics, all loop diuretics, excuse me, have a very short duration of action, leaving time for the kidney to restore salt balance after the diuretic. So it may be logical to consider an extended release form of torsemide. And I'll show you results with an extended release form that increase the duration of action of torsemide from 3 to 4 to 5 hours up to 10 to 12 hours. And then we may consider blocking reabsorption downstream in these segments that have had an adaptive increase in sodium transport. And that would include the use of thiazides, as in the last case, to block the distal tubule, amiloride or perhaps triamterene to block the epithelial sodium channel in the collecting duct, or mineralocorticoreceptor antagonists such as spironolactone or eplerenone to block the action of aldosterone that is expressed at this site. And perhaps to use a drug such as tolvaptan that blocks the vasopressin V2 receptor and thereby blocks free water reabsorption in the terminal nephron. In studies that we did with Jeff Testani, we are using markers of proximal reabsorption and other methods, we concluded that about 20% of diuretic resistance in acute heart failure was due to enhanced proximal reabsorption, and a rather greater amount, in fact quite a bit greater amount, about 80%, to enhanced reabsorption in downstream segments. So we'll return to this and the concept that we may even consider blocking several of these sites simultaneously as we move through the talk. But it raises the question now of what are the causes of potassium loss with loop and thiazide diuretics? And this reminds you that loop diuretics block the sodium-potassium 2-chloride, or NKCC2 transporter, and the potassium immediately recycles through this renal itomedullary potassium channel in a futile cycle shown here. So the net effect is to reabsorb sodium and 2 chlorides, but not potassium. So loop diuretics don't increase the delivery of potassium out of the loop segment. And so the increased potassium excretion must be a downstream segment phenomenon. Thiazides work on the potassium chloride, or NKCC2 cotransporter, which is linked to potassium secretion here. But increased, so thiazides block this and lead to some increase in K secretion in the distal tubule. But most of the increase in potassium secretion is in the collecting ducts due to increased activity of ENaC and K secretion through the ROM-K in the collecting duct cells. So most sodium excretion in the collecting duct is through the epithelial sodium channel. And that's unusual in that it transports sodium without an accompanying anion. And therefore greater transport through ENaC leads to greater electronegativity of the lumen, which can get to very high levels of -80 millivolts. A greater electronegativity provides greater force for the secretion of potassium and hydrogen ions. So we may say that diuretics working upstream, thiazides and loop diuretics, increase delivery of sodium to ENaC, which thereby generates more luminal electronegativity and engenders potassium and hydrogen ion secretion and a hypokalemic metabolic alkalosis. And therefore drugs like amiloride, or perhaps triamterene, or aldosterone antagonist, MRAs, such as spironolactone or eplerenone, are logical accompaniments of patients requiring large doses of loop diuretics and thiazides who develop this complication of hypokalemic metabolic alkalosis. So let's turn now to some more novel diuretic strategies in heart failure that I hope will be new ideas for most of you. First, how can hydralazine be used as a vasodilator, and what effects might that have? What about extending the duration of loop diuretics? How do SGLT2 inhibitors interact with loop diuretics? And what about sequential nephron blockade, which is the blockade of multiple transport processes simultaneously? So first then, hydralazine. Can this provide a hemodynamic approach to managing diuretic resistance in heart failure? And to illustrate this, I want to show you a case that from the wards here at Georgetown, that a fellow, Mohammed al-Shahiri, when he was actually a first-year fellow, presented to us at our weekly seminar series of case discussions. And he had gathered the data for this case, which I've reproduced here with him as we're preparing it for a case presentation. And this was a patient with severe diuretic resistance because of heart failure and preserved ejection fraction, for which there are no established specific forms of treatment, unlike heart failure with reduced ejection fraction. So this patient had HFpEF and a degree of renal insufficiency and very severe diuretic resistance with pulmonary edema and peripheral edema. And in the basal stage here was excreting almost no sodium. The fraction excretion of sodium was 0.1, and the daily fluid output was about 400 mils. As he was established, she actually, on a regime of 80 milligrams twice daily of furosemide, together with 250 milligrams twice a day of chlorothiazide, you'll see that there was some increase in fraction excretion of sodium and urine volume, but it was relatively modest. The treatment was then changed to round-the-clock intravenous furosemide and hydrochlorothiazide. And this increased fraction excretion of sodium to about 2%, and urine output to about, this is covered up, but about 1.5 liters a day. But the patient still had severe edema. At this point, the patient was treated with a small dose of hydralazine, 10 milligrams 3 times daily. And as you know, most patients receive doses of 50 or 100 milligrams 2 or 3 times daily. This small dose doubled fraction excretion of sodium and doubled urine output, such that the patient could be discharged from the ICU, and in fact was discharged from the hospital, and has made a very good recovery. So what's going on here? The key, I think, is that the hydralazine was given during blockade of reabsorption in the loop of Henle and the distal tubule. So during full blockade of distal reabsorption, hydralazine doubled urine output and fraction excretion of sodium, and therefore it must have reduced sodium reabsorption in the proximal tubule. However, hydralazine has no known direct effect on renal tubular epithelial cells. And so we conclude then that hydralazine had reduced reabsorption in the proximal tubule by hemodynamic action. And to put this in context then, hydralazine regularly increases renal blood flow, which will increase the delivery of diuretics to their site of renal secretion by the organic anion transporter in the proximal tubule. So more diuretic will get to the site of action in the loop of Henle. Additionally, hydralazine decreases the filtration fraction substantially. And the filtration fraction is the GFR divided by the renal plasma flow, or the fraction of the renal plasma flow that is filtered at the glomerulus. Now, as blood flows through the glomerulus, water is filtered, that's the GFR, so that the blood then exiting the glomerulus has an increased concentration of proteins and therefore an increased oncotic pressure. And this increased oncotic pressure is required to take up fluid and water from the interstitium into the bloodstream and clear it away from the kidney. And any reduction in oncotic pressure caused by a reduction in filtration fraction reduces the uptake of fluid and reduces the proximal reabsorption. So this hemodynamic action to reduce filtration fraction and hence uptake of fluid by the proximal tubule is likely an important component of this remarkable effect of hydralazine in this patient. So we're planning to investigate this further and more systematically as an adjunct to the treatment of diuretic resistance in heart failure. And by the way, the trick is to use a very low dose of hydralazine, which has a very good effect on renal hemodynamics. Too big a dose, the traditional doses that I mentioned, lower blood pressure, and a fall in blood pressure overwhelms all other mechanisms and induces renal salt retention. So low dose hydralazine, if you're going to try it, is the way to go. So the next question is, can extending the short duration of loop diuretic action of 4 to 6 hours at best, improve loop diuretic efficacy. And here I show you results with regular furosemide, 40 milligrams, regular torsemide, and this torsemide extended release, whose duration was extended to 10 to 12 hours by a new formulation. As we saw earlier, furosemide on a high salt diet induces no loss of salt over 24 hours. Torsemide actually was not significant. It looks a little better, but extended release torsemide now causes a large loss of salt, even on a high salt intake. And this was clearly a increased efficacy relative to the short traditional immediate release torsemide. Interestingly, the GFR did not fall as much with the extended release as it did with the furosemide or the immediate release. So as we looked about what's going on, we identified a number of mechanisms. Firstly, we can relate the delivery of the diuretic to the tubules from the rate of diuretic excretion, because once secreted, diuretics are confined to the tubules. So the more excreted means the more presented to the thick ascending limb. And sure enough, as we give the diuretic, more and more is excreted, and that is matched by a greater and greater increase in salt excretion. But what we found for the first time is that there's marked hysteresis in this relationship. So the same amount of sodium getting to the distal tubules as the dose is being reduced here has a much reduced effect on sodium excretion compared to that during the ascending phase. So one important reason why the extended release was more effective is that it was not only extended, it was more modest, delayed release, so that the subject spent more time on this ascending or very sensitive phase of the dose-response relationship. A second reason is that normally the salt loss followed, as we've seen, by salt retention, and with the delayed release formulation, then there is less time for the kidney to regain the salt and water lost after the diuresis. And the third reason was that the GFR was not reduced as much as with the more abrupt diuresis. And these three factors together combined to make the extended release formulation twice as effective in inducing salt loss as the immediate release. And time will tell whether this translates to greater efficacy in the treatment of patients with heart failure. We don't know that yet. So can blockade of sodium glucose reabsorption in the proximal tubule with SGLT2s enhance the response to a loop diuretic? And these SGLT2s really are the beautiful child of the cardiologists and nephrologists now, with so many beneficial effects. What about their use in alleviating diuretic resistance? So I'll remind you that SGLT2 is expressed in the proximal tubule, where it reabsorbs sodium coupled with glucose. Glucose exits via GLUT2 and sodium by the sodium-potassium ATPase. SGLT1 is a relatively minor player. So SGLT2 is the main portal for for glucose reabsorption. However, even in diabetes, reabsorption of sodium with glucose accounts for only about 5 to 8% of proximal sodium reabsorption. The great majority is reabsorbed by the sodium hydrogen exchanger 3, NHE3. So this isn't a very promising, at first sight, site for sodium, for inhibition of sodium reabsorption or alleviation of diuretic resistance. However, new insights into this process in this rapidly evolving field have taught us that SGLT2 is linked by a couple of proteins, MAP17 and PDZK1, directly linked to NHE3 and actually to other proximal reabsorptive proteins, so that activation of SGLT2 activates NHE3, or inhibition of SGLT2 inhibits sodium glucose, inhibition of SGLT2 inhibits NHE3. And in micropuncture studies, we can show that blockade of SGLT2 blocks about 30% of proximal reabsorption in a rat kidney. And that's because of this linkage shown here. The net effect then is to increase the delivery of sodium and chloride out of the proximal tubule into the loop of Henle, which is the site of action of loop diuretics, and therefore to increase the target for loop diuretics. So this led to two hypotheses here for the interaction of an SGLT2 and a loop diuretic. First, as I've indicated, SGLT2 inhibitors pass on more salt to the thick ascending limb, and therefore increase the target for loop diuretics and increase the efficacy of loop diuretics in inducing salt loss. On the other hand, loop diuretics lead to loss of salt, generation of angiotensin II that acts on the AT1 receptors to enhance the proximal expression of SGLT2 and NHE3, and thereby to increase the target for SGLT2 inhibitors. So this suggests there may be indeed two-way synergy between these groups of agents. And this we examined in a clinical study that was published a couple of years previous. So here we had three groups of 14, about 40 normal subjects on a controlled salt intake. After they were in balance, one group had a single dose of bumetanide, and it led to an increase in sodium excretion of about 110 millimoles. Another group had a single dose of dapagliflozin in blue, and that led to a rather modest sodium excretion of about 35 millimoles. Another group was given dapagliflozin for a week and then had a single dose of bumetanide. And you'll see that the prior dapagliflozin treatment here had induced a bigger rise in sodium excretion with the loop diuretic, about a 30% rise, now rather substantial. Perhaps even more impressive, a fourth group here was given a loop diuretic for a week and then a single dose of the SGLT2 inhibitor, dapagliflozin, and the rather modest diuresis was transformed into a diuresis that was pretty similar to a loop diuretic, about a 2 to 3-fold increase in salt loss. So this indicates then that loop diuretics and SGLT2 inhibitors can have mutual two-way synergy for salt loss, at least in the first instance, or we studied over the course of a week, and may be an interesting strategy to employ in diuretic-resistant patients, for example, those with heart failure. We could talk more about that. So lastly, others have asked the question, should all the major nephron transporters be blocked simultaneously with a technique of sequential nephron blockade, all of these things blocked, to release the kidney from diuretic resistance and prevent the compensatory increase in distal potassium and hydrogen ion secretion and free water reabsorption that leads to electrolyte disturbances? This would seem to be a pretty drastic and rather dangerous process, but the results are rather fascinating. Here are the first results published for sequential nephron blockade, which is undergoing rather widespread investigation at the moment. It was a group of 17 patients with severe diuretic-resistant heart failure. Over 3 days, they were given a large dose of furosemide IV together with a large dose of an aldosterone antagonist, a large dose of a thiazide, a large dose of a proximal diuretic, and a large dose of a vasopressin antagonist simultaneously here. The effect was a 7-kilogram loss of body weight and about a 2 to 3 liter loss of fluid each day. And I might say they all had quite severe renal insufficiency, which perhaps limited this fluid loss in this particular case. Remarkably, all improved. But if we look at changes in these parameters, blood pressure, serum sodium, serum potassium, acid base, and GFR, there were no significant changes in any of these parameters, despite the loss of a lot of salt and water over this period. Because if we think about it for a moment, what we're really doing is forcing the kidney to excrete almost a pure glomerular filtrate, unmodified by the tubules, or largely unmodified. And it's this tubular modification that accounts for the resistance to diuretic effectiveness and the ongoing secretion of potassium and hydrogen ion and reabsorption of free water that lead to the electrolyte disturbances. So that by paralyzing all of these processes together, we, in a sense, simplify the process. We get the response we want, loss of salt and water, and we don't get the adaptive changes that lead to electrolyte disturbance. Now, this must be considered at the moment experimental. We're waiting for further, more controlled studies, but I show it to you because it's sort of fascinating, and it's likely a wave of the future. So when we think of decompensated heart failure, we know then there's activation of baroreceptors driving sympathetic nervous system. There is a major stimulus to renin-angiotensin. And these not only modify renal hemodynamics in such a way as to enhance proximal reabsorption, but also, as we mentioned, enhance the expression of the major transporters in the proximal nephron, enhancing active sodium reabsorption. The two together increase sodium reabsorption in the proximal tubular loop of Henle. Additionally, angiotensin-dependent aldosterone secretion enhances the activity of ENaC and sodium reabsorption in the distal nephron. And the two together underlie the expansion of blood volume and interstitial fluid volume that leads to the clinical findings of congestion and edema. So I'll return to this and put in the diuretics and the other treatments as when we get to the concluding slide. But I want to spend a moment talking about the nephrotic syndrome. And we may wonder here whether this is due to an overfill of the circulation, an overfill edema, or underfill because of leaking of water out from the circulation because of decreased protein and oncotic pressure, which is the traditional concept. And what might be the role of amiloride? We'll come to that. So with nephrotic syndrome, the primary disturbance is increased protein filtration at the glomerulus. And in the underfill hypothesis, this leads to a reduction in serum albumin and oncotic pressure, and therefore the leak of fluid into the interstitium, leading to edema. The leak of fluid lowers the blood volume, which activates neurohumoral mechanisms to force the kidney to reabsorb salt and water and further contribute to edema. A very logical and appealing concept. On the other hand, the overfill hypothesis is that increased tubular protein delivery is the initial factor. And this, as we'll see, activates ENaC, to drive sodium reabsorption in the distal nephron and enhance renal tubular and fluid reabsorption, leading to an overflow edema and a well-maintained blood volume. So you'll see that if the underfill is correct, we'd expect a lower blood volume and greater values for renin-angiotensin and aldosterone. Whereas two large studies shown here have shown no effect, no maintained blood volume and a maintained renin-angiotensin-aldosterone system, strongly favoring the overfill hypothesis as the predominant mechanism for salt retention in the nephrotic syndrome. There are some groups of children, I will tell you for sure, who have a characteristic underfill physiology, but in the adult, the majority fulfill the criteria of the overfill. So then let's consider how increased tubular protein delivery might lead to renal salt retention. And take us back to a classical and brilliant experiment by Iokuni Ishikawa. He injected a drug into one renal artery of a rat that increases the protein permeability of the glomerulus so as to cause a unilateral nephrotic syndrome. Both kidneys then had the same oncotic pressure of the plasma, the same renin-angiotensin system, same sympathetic nervous system. But he showed that the kidney that was filtering more protein excreted only a third of the volume or sodium of the contralateral control kidney. And when he did micropuncture on the end of the proximal tubule, which is the last point of the nephron we can micropuncture, you'll see that there was exactly the same delivery of sodium to this site in the nephrotic kidney as in the control, despite much less sodium in the urine. This proved then that the site of increased sodium reabsorption in the nephrotic syndrome was in the collecting ducts. And this was a new finding at the time. So how can an increased protein filtration force collecting duct salt reabsorption? And so we have to go forward now about 20 years to another set of very brilliant experiments by Ollie Scott and his colleagues in Copenhagen. They set up a model of the collecting duct. Actually, it was a frog egg transfected with ENaC. It doesn't really matter, it just gives you better control. And when they incubated these frog eggs with control urine, normal people's urine, there was very little activity of the ENaC current here, which is a measure of the ENaC activity. But remarkably, when they incubated the frog egg with nephrotic urine, there was a huge increase in the current, which indeed was due to activation of ENaC because it was blocked by amiloride, which is a specific blocker of the ENaC. And it was due to a proteolytic process because it could be prevented by a protein, which is a generalized protease inhibitor. And they showed that it was related to prostasin because if they silence prostasin, they silence this effect. So what's going on then is that when we filter protein at our glomerulus, we notice increased albumin and protein in the urine. We're also filtering a number of proteases. Most important is probably plasminogen. And as plasminogen passes down the tubules, it meets TPA with a large generation of plasmin, which is a very effective protease that has two main effects. It activates prostasin that cleaves ENaC, and it directly cleaves ENaC. And it's now recognized that ENaC has a tail that projects into the lumen of the collecting duct. And if this tail is broken open by a protease, such as activated prostasin or directly by plasmin, the channel is fixed in the open position, anchored in the membrane, and leads to ongoing inappropriate renal sodium reabsorption, leading to edema. So this appears to be the pathophysiologic key process in the nephrotic syndrome that accounts for the overflow edema that we see. So we can get rid of then this concept that the the edema in nephrotic syndrome is a response to a low blood volume. It's rather due to enhanced ENaC activity, an overflow phenomenon, in which case amiloride should be a very effective diuretic. It's rather remarkable now that 19 years after this abstract was published, and never published as a full paper, we still don't have a really good clinical study that investigates this hypothesis. But the data here in 8 children with the nephrotic syndrome are very appealing. On the first day, they were given no particular treatment and had very little sodium excretion. And on one occasion, they were given a dose of amiloride, normally a very weak diuretic that has a major loss of sodium that is at least equivalent to the other occasion when they were given furosemide. And when they were given both together, the effects were additive, showing then that at least in this study, amiloride is a very effective diuretic in heavily proteinuria subjects. It acts as a different wave to furosemide, as we might expect, in an additive way, suggesting then that when we have a diuretic-resistant patient with a nephrotic syndrome, we should think of the use of amiloride either as a primary agent or to introduce when the patient is no longer fully responsive to furosemide. So let's conclude now and think about how we should approach nephrotic syndrome and heart failure with this information and a general algorithm as we come to the end. So in the nephrotic syndrome, we've been through this diagram here. First, we'd like then to reduce the glomerular protein filtration. And the classic way to do that is to administer an angiotensin-converting enzyme inhibitor or an ARB. And they surely do reduce proteinuria, but only by about 30%. In our division, Dr. Wen Shen has undertaken a very original study in which she has treated patients with nephrotic proteinuria established on a fully effective dose of ACE/ARBs with amiloride, and shown that amiloride, remarkably, causes a further 30 to 40% reduction in proteinuria. This is a novel finding, and we don't really fully understand the mechanism yet. Now, I think we do understand that amiloride also has an effect downstream on the nephron directly to block the overactive ENaC that is the site for the increased sodium reabsorption and the edema formation. So amiloride here is becoming a very appealing treatment for the nephrotic syndrome, working both at the origin of the problem of glomerular filtration of protein and the effector site of the overactive ENaC. And therefore, you should have a low threshold for considering amiloride, providing the patient is not hyperkalemic, because amiloride increases serum potassium. So what about strategies for heart failure? Oops, sorry. Strategies for heart failure. So in decompensated heart failure, we'd certainly like to use a strategy of an ACE or an ARB to block the overactive renin-angiotensin system that is expressed by enhanced reabsorption in the proximal tubule, either by hemodynamic effects, as we talked about, or by enhancing active sodium transport proximally, or by activating aldosterone, an active sodium transport in the distal nephron. We talked about how hydralazine may provide an alternative or additional hemodynamic approach to decrease proximal reabsorption and relieve diuretic resistance when added to loop diuretic therapy. We can also consider a number of diuretic strategies. SGLT2 inhibitors block SGLT2 in the proximal tubule, and as we showed, synergistically enhance salt loss with a loop diuretic. We could consider substituting torsemide, or perhaps in the future, even more effective may be extended release torsemide. It is a better way to inhibit NKCC2 in the loop and a more secure pharmacokinetic drug than furosemide. We can consider the use of a thiazide diuretic to block NCC in the early distal tubule, and/or a drug like amiloride to block ENaC, or we could use an aldosterone antagonist such as spironolactone, which would not only block the effects of aldosterone in the collecting ducts, but also some of its adverse effects in the body, such as in the heart. And all of those should be combined with some effort to restrict salt intake if you find that sodium excretion indicates a salt intake of greater than 2 to 3 grams of sodium daily. And as I indicated, a novel strategy is to use some of these approaches simultaneously in a strategy of sequential nephron blockade. So the last slide, and I see we've come to time, is the approach. So we select the diuretic target, we look for non-compliance, we measure the sodium excretion and increase the dose appropriately. We measure the protein excretion and use amiloride if it's high, but if it's not, we can add a thiazide or a proximal diuretic. If we're still in trouble, then you can turn to intravenous or continuous infusions of loop diuretics with a thiazide. And if it still doesn't relieve edema, then the experimental approach is sequential nephron blockade. So thank you very much. I'm sorry, I've just gone over time. Appreciate your attention to the talk. Thank you very much.